I think we can get started. Welcome. Good morning, everyone. I'm Larissa Mooney, and it is my distinct pleasure to introduce my wonderful colleague, Dr. Karen Miotto, for today's Grand Rounds. Dr. Miotto is a professor of clinical psychiatry in the Department of Psychiatry here at UCLA, where she is not only known for her clinical expertise, but also for her unwavering commitment to the health and well-being of her fellow physicians. Today, Dr. Miotto will present on a crucially important topic: staying in practice, proactive strategies for maintaining your medical license. This presentation will delve into practical, proactive strategies that every physician can employ to safeguard their professional license. Dr. Miotto's dedication to physician health is exemplified by her leadership in various initiatives: the UCLA Physician Health Committee, the director of the DGSOM Behavioral Wellness Center, and the past president to the California Public Protection and Physician Health. And on a personal note, Dr. Miotto has been my clinical and professional mentor since I joined UCLA faculty back in 2008. And I have witnessed and seen her dedication to these roles and admire her work. So with that said, I will turn this over to Dr. Miotto. Thanks.
Well, thank you, Dr. Mooney, for the warm introduction. I'm delighted to be here to speak on this important topic. And I want to give credit to Erica Morris, who was a lawyer who worked with the Physician Health Program, and she contributed to this lecture, as well as Jason Jalil, who has done many evaluations for the medical board. And so we all come at it with our different expertise related to the medical board. So let's get started. So today we're really going to understand a bit more about what the medical board does. What are the reasons for disciplinary behavior? And this whole term, unprofessional behavior, what does that mean to the medical board? And certainly talk about strategies. And one of the essential strategies is documentation. And then we're going to delve into prescribing controlled substance, because that really is an issue in the news and on the mind of the regulators, as well as talk about cures. So the medical board, it has three components, right? They provide our license, and it could be the nursing board, the psychology board, whatever board you're under. They provide our license, they set the requirements, they regulate medicine. As you know, right now, different states have different regulations about what you can do in terms or cannot do in the practice of medicine. And certainly they discipline or enforce. Now, as you'll see, this little lonely square here is a state physician health program. And California was one of the first states to have a diversion program where doctors could be diverted in lieu of sanctions if they were suffering from an impaired condition such as a substance use disorder. We lost our program in 2008, but I just want you to know there's good news on the horizon. The Medical Board of California is really looking at best practice across the country. And so I think many of us who watch the medical board and follow the medical board really have reason for optimism right now. So when you think about, is it your right to practice medicine? You have a medical degree. Well, actually, no, the Medical Board of California is very clear it's your privilege to practice medicine in the state of California. And they're there predominantly to monitor safety, as we talked about the requirements. And they are the ones that create the regulations around the Medical Practice Act of California. I went through my own whole training and I never even heard of the Medical Practice Act. And now I know it quite well. They also adopt the policies related to the practice of medicine in the state. What else does the medical board? Well, the medical board is a lookup feature. You'll probably find this notice to patients. Medical doctors on many of the polls around UCLA, so you can check. They alert us when a doctor is being disciplined, and as well as the other boards letting people know. So I don't know if any of you have on your phone, it's called the Breeze. You can actually have an application and look up a doctor any place in any time. And this has been something that the patients, the consumers have asked for. They want to be able to look up their physicians. And so when you do a search, this is what it would look like. You would see if there was an action, if the doctor had a felony, misdemeanor, if there was a malpractice judgment against the doctor, because any judgment over $30,000 gets reported to the Medical Board of California. And then other things related to the status of your doctor in terms of a regulatory sense. So what does the board actually do? Well, they receive complaints. So you can go on their website or that phone app and make a complaint against a doctor, a patient, a family member, an insurer, a pharmacy. Now, the complaints they take most seriously are complaints where people they identify who they are. But there's also a capacity to make an anonymous complaint, and they will, because some people are afraid to report, they will take those complaints serious depending on the gravity of the report. Yeah, but it's much harder. And then what does the board do? And we're going to talk about the long process involved in what they do. Well, they can issue fines. They can let a physician know that they've engaged in an infraction of the Medical Practice Act. Under administrative law, they can issue a public letter of reprimand. And we're actually going to talk about a case where that occurred in probation, suspension, and revocation. So let's talk about how they enforce. So the medical board will receive complaints, and then they refer them on to their central complaint unit, who takes a look at, does this meet a violation of the medical practice? Is there enough information here that we should pass it on to the investigation unit and file charges and eventually disciplinary action? In this process are experts for the medical board, and people like Tim Fong, Jason Jalil, maybe many of you on this webinar have actually done work for the medical board, and we actually encourage you a bit as your civic duty. And it's also so informative. When you do a case for the medical board, you just learn a lot about the practice of medicine, the standard of care, the regulations that apply. Quite frightening. The medical board, Department of Consumer Affairs, essentially, the district of attorney for the state is the one that brings charges against physicians, and that's what it looked like. So what are the proportion of complaints and charges filed? Well, as you see, the medical board, and this is data from 22-23, received over 9,000 complaints. And of those, about 1,000 investigations were opened. And then the bottom of the triangle was a much smaller number of administrative actions actually taken. And I want to show you sort of the problem sometimes, which happens is that the complainant can issue a complaint, but when the board tries to reach out and get additional information, they don't provide additional information. Or perhaps there's no violation, insufficient evidence, or it's outside of the board's jurisdiction. So somebody can complain and say, my doctor was late 12 times and the parking at UCLA is $18. Well, now that's a serious concern for that patient. But it's not within the jurisdiction of the medical board. And so we're going to deal on which areas come to the surface for the medical board. So of those over 9,000 complaints, certainly gross negligence, incompetence is the major category of complaints that you see in that far column that they're receiving from the public. But that's also from the public, unprofessional conduct, which is noteworthy, and we're going to talk about what that looks like. If a professional group reports, some of those proportions retain. A government agency may be reporting unprofessional conduct. Perhaps a pharmacy and anonymous. So that big bucket of gross negligence and incompetence is important. So we're going to talk about negligence. We're going to touch on substance use. We're going to also talk about boundaries. Why is boundaries important? Because it's the leading cause of complaints about mental health professionals. And I think we could all have a discussion on why that might be. We're going to really talk about the importance of medical records because, as you know, if it is not documented, it was not done. So you may have done a detailed suicide assessment. If it's not near known, or is your note complete? Essentially, you did not do a suicide assessment. So now negligent, I think we all remember the 4 Ds of negligence. I mean, you have to be in a patient care relationship. So it has to be your patient, your duty to care. You have to have deviated from the standard of care. There has to be damages, and there has to be direct causes. Did the doctor do this? Well, certainly if it's surgery on the wrong part, I think we can all say, oh my goodness, that fulfills the criteria of the Ds very easily. Now, what about in psychiatric practice? Well, what if a doctor was still only prescribing tricycles and the person had a cardiac condition and there was an unturned outcome? Of course, we would say, well, that was incompetent because, my goodness, there's many, and is that doctor dated? And so I don't know if anybody has seen the podcast Dr. Death, which has become quite a sensation. It's really about a neurosurgeon who was inexperienced, and there were unfortunately adverse outcomes and even death. And so he was charged with negligence and incompetence. Now, substance abuse, substance misuse, I'm sorry, we don't use that word anymore, substance misuse. Actually, Business and Professional Code 2239 prohibits excessive use of drugs or alcohol. And you may say, well, I'm it's a Saturday night and I'm not on call, I can use whatever I use whenever I use it. Well, of course, if you come to the attention of the medical board, for example, for a DUI, that can be considered by the medical board unprofessional behavior of a physician. You are considered a safety sensitive worker, and your actions outside of your workday by the board reflects on your professional integrity. To the point that doctors who do get a DUI have to self-report. And we've seen situations where doctors who failed to self-report had even more consequences and a fine. But how many physicians actually know that if they're charged with a criminal violation that they have to? I don't think it's common knowledge, and so that's why I'm glad you joined this webinar so we can all stay up to date on the requirements. Often law enforcement will also inform the medical board and so it's very well spelled out on the 802 form when you need to report. And then that will open an investigation by the medical board. And unfortunately, even with Uber and Lyft, we are still seeing physicians. And it's tragic. You go to your parents' 35th wedding anniversary or your 55th wedding anniversary, and you end up with a DUI with adverse outcomes for your career. So really important to consider safety in terms of your practices and your medical license. Well, what about cannabis? I think this whole question is quite confusing, right? Everyone just says, well, cannabis is legal for recreational use, so I can use cannabis, and the medical board should have no say at all about my cannabis use. And this is a example of a case that was given to us by the medical board when we asked them how did they handle cannabis. They said, we treat it like any other potentially impairing substance. And this was a neurosurgery resident whose partner called the medical board and said she is using, before she goes to work, she's under the influence when she performs surgery. This had grave consequences, and after a long period of investigation, she ended up getting a public letter of reprimand. But it took a long time, and it marred her career. This whole issue is going to be important. This is what the medical board said, but there is a new assembly bill that we're trying to analyze and talk to legal counsel that says it's unlawful for an employer to discriminate against a person or penalize related to using cannabis off the job. Well, certainly we fall under federal laws, the drug-free workplace. So that doesn't mean there can't be reasonable suspicion drug testing of a physician if they're using something that smells like cannabis in the call. It will be tested, and it doesn't matter what Assembly Bill 2188, but it's really unfolding. And that's why I think it becomes confusing. And I think many of the trainees tell me at the VA, you're still tested, it's federal, you still potentially can be randomly tested for cannabis. So just important to know as a licensure safeguard. All right. Well, So that's important. Substance use can be considered unprofessional conduct. But what about the other big bucket that mental health professionals find themselves meeting the board about? Complaints from patients, complaints from families. And that's sexual misconducts and boundary violations. And I've talked to many residents. They say they're going to work out sexual countertransference in the therapy session. And I believe in all those things, but I think it's also very important to be aware that not only is it unethical, but that physicians who have uh, uh, had actions against their license related to certain substance use and boundary violations are now required to have a patient sign in advance of seeing them, that so that you can say, oh, I know that doctor has been charged with a bound. And then at that point, you can say, well, I'm not coming to see you. So this is a written requirement. And because of some of the high profile violations of this ethical boundary, there are also requirements for facilities. So not only if you're charged, do you have to tell a patient, but now health facilities are required to tell the medical board within 15 days that they receive notice about a patient complaint about sexual violence and sexual harassment. Well, so this has really swept up doctors, because many doctors don't even know that their health facility has this requirement. And, this doesn't say, oh, health facility, please evaluate that allegation and let us know if the patient was psychotic on a 5150. It doesn't say that. It says report it to the medical board. And I think this is, again, because of there has been a breakdown in the trust with some of these high profile physicians who have been accused. And so this is also a part of the requirement in the state of California. And if this does happen, please call the physician health committee. Not that we're going to address this boundary violation, but we want to make sure we provide supports for the doctors and direct them to various resources. And so that is the Patient's Right to Know Act and the sister regulation requiring hospitals to report. So how do we protect our license? I just think supervision and consultation is so important in this regard. And one thing that I want to bring up is texting. I know texting is enormously convenient for our patients, and many of our patients like to text to our work set. But different trainees and people have shown me the text, and sometimes they can have very intimate connotations, and the patient's texting at midnight as if you were their close friend. So I urge people, when possible, use the MyChart portal. That's an official portal. It's HIPAA cleared. There's a record of what happened. Maybe somebody's managing your pool of message. They can intervene if those messages look like they don't make sense given the circumstances of patient care. So one important ways to protect yourself. And now, having a chaperone, I think, is so important. People have complained the doctor touched my hair. Well, I think what we're learning is people need more information. I'm going to listen to your lungs in the back and I'm going to move your hair. Is that okay? Just so people are able to anticipate what's happening in general exams, but as well as sensitive exams. Let's switch gears and talk about charting. Now, staying up on charting is enormous work, and will AI hurry up and get here so I can have my AI scribe help me get all these done in real time. And I think we all know help is on the way, but it's not here yet. So you're left with optimizing your templates. Maybe some of you use Fluency Direct, you dictate, that helps. But if you're seeing patients back to back and you're done at 8 o'clock at night, which I often am, it's like, do I dictate that? So I really appreciate the difficulty. Dr. Ling, one of my colleagues, used to always ask me, does the medical record say what kind of patient the doctor had? I'd say, well, yeah, we hope so. And he would say, no, the medical record says tells you what kind of doctor is treating the patient. I think there's really a lot to that. And as we said, the medical board says, if it is not documented. So at 8 o'clock at night, if I don't do my behavioral health checklist for a suicidal patient, and that patient commits suicide, did I do the assessment? So that's why really prioritizing your patients with high acuity and finding your rhythm and flow until we get AI scribes. So for us, we know suicide risk is very important to assess. Accurate diagnosis and billing. I think you've all seen in the news people up billing. That's why when compliance reviewed my records, I didn't think, oh, that's terrible. I think, I want to know, how do I stay compliant? Do I have to do 4 review of systems? Or no, what I have to do is document my medical decision making. I went to an APA webinar, excellent webinar on documenting medical decision making. And some of the pearls from that webinar were just the things you all think of. Are you documenting I thought about bipolar disorder, but their elation was after they published their book. I do not think they meet criteria for bipolar. That's why I went ahead and prescribed a antidepressant unopposed to a mood stabilizer. Because if that person goes on and spends the family fortune in their manic episode, is there any assessment that you actually thought about that differential diagnosis? And you told them, this elation, I'm not worried about it. And I know your maternal grandmother had bipolar, but nobody in your immediate, to actually document that. Because when a medical review individual looks at your record, you can say, well, I thought very carefully about this. But if there's nothing that says so, rather than the 6-paragraph history of present illness, I urge you to the 6-paragraph medical decision making. Call it medical decision making. Why did you recommend that pharmacotherapy? Because they failed 3 other medications, didn't have an adequate response. Which we're required to do if people are on hold, if people have complicated medical history, how did you coordinate care? Did you want their ammonia level measured before you hospitalized them, for example, because you thought they might have hepatic encephalitis before you put them on a hold? So all those things you do, and I am confident the doctors that I work with and the residents, they do all that. I think where we fall short. One example, for example, is people often write and prescribe Wellbutrin. Well, they refill the Wellbutrin 450, but they meant to do that. They were down titrating the dose. But they didn't put that because they just said refill a little bit, and they clicked refill because they're so busy. But then they also prescribed doxepin 10 with the Wellbutrin, and the Wellbutrin was there to augment the Remeron, and so the person has a seizure. Now, that wasn't intended because they actually, but those are such great reminders. You're writing refilled Wellbutrin, XL 150, down titrated, added additional medication. And then anybody that comes back and reviews your chart, your medical decision making is crystal clear to them. And plus, it's a good reminder because sometimes on Epic, it'll auto-populate what you're refilling. And you're like, did I refill Wellbutrin slow release 100 milligrams TID? And it auto-populated and you can be in a hurry. So medical decision-making, the APA actually encourages to make that the heading of your section. Not assessment and plan, medical decision-making. So that it's very clear. And then we know we bill based on medical. So you were looking at their thyroid, you were looking at their lithium level, their bipolar disease, their alcohol use, and you prescribed the Nicotrol inhaler. Now that's you need to bill up for that because that's legit. And there's real documentation of that medical decision. Okay, we're on the home stretch because I really want to save time to talk with you and hear your questions and concerns. I think, though, criminal conduct is important. As we said, if it's a DUI, misdemeanor, or felony, you're required to report it. And we talked about it, really unprofessional conduct, whether it's documentation, poor documentation, substance use, certainly will be taken into account by the medical board. If somebody is up-billing and they're charged with fraud, very important. There's lots of salacious examples that you can read if you read the medical board. If you subscribe to the medical board, you can see their action report, what disciplines have been what physicians have been disciplined by what. I peruse that to see if there's any new trends. And one of the new trends that really applies directly for many psychiatrists is what's going on in the ADHD prescribing realm. And I just want to, these are New York Times stories about cerebral and about None, N-O-N-E. And None was a San Francisco-based startup. And cerebral marketed heavily on social media, on TikTok. And so they would do TikTok pictures of before my diagnosis of ADHD, I couldn't get anything done. Now I'm a rock star. You look at them and you think, oh my gosh, I want a diagnosis of ADHD because if I can get as much done as they do, wow. And as you can imagine, it drew a lot of attention from people. And I think it added to the concern that we already have as clinicians about, is this performance enhancement? Is it ADHD? How to be vigilant? The Now was accused of $100 million in fraud, and their scheme was a subscription. You would really see a doctor once, and then you would subscribe to get your monthly Adderall. Well, I can tell you right now, my colleagues in San Francisco who do medical legal work are just inundated with cases with all these doctors that thought that they were doing something legit, only to find out that they were only seeing the patient once and the rest was being shipped. One of my colleagues at UCLA prescribed Adderall to his patient in Palm Springs. The pharmacist called up and said, "Do you work for none? Do you have a follow-up patient appointment with this patient? What kind of practice do you have?" So when we think about what happened with opioids and the large opioid settlements, you can see why pharmacies are like, I am not going to be the pill dispenser for Adderall from these companies, really, which there's clear documentation, 50,000 shipments of Adderall by and large to people that there were often two questions for the screening. Do you feel overwhelmed? And are you behind in your work? If those are the criteria, I think all of us at Grand Rounds would probably meet those criteria. So I'm here just to remind you about the federal code of regulations, because I'm always looking at what are doctors required to do and not required to do. And I'll look on the medical board website and I sometimes can't find the answer. Well, the DEA practitioner's manual, I don't know if any of you have been reading it recently. Probably not. It lays out refilling a prescription of a Schedule II controlled substance. Adderall is prohibited. Does anybody even know that? Well, I think you do. Many of you write Adderall 30, refills no, 0, right? But then you go on to issue the next fill day, 30 days, and the next. So you do, some people do 1 of 3, 2 of 3, and 3 of 3. Because those other prescriptions have to be separate. And I think this last item 3 and 4 are very important. The practitioner concludes that the patient with multiple prescriptions in this manner does not create an undue risk for diversion or abuse. This item here is what UCLA will give you a pop-up. Did you do a baseline screen, drug of abuse screen on this patient? You're prescribing Adderall. And you think, well, I don't have to do it. But it's always good to enter that safeguard. It allows you to have a conversation with the patient. Well, this medication, I want to just review safe handling of this medication. It can be bought, sold, stolen, diverted. And also because it is a controlled substance where there are a percentage of people who can develop problematic use or addiction, we're going to get this urine screen. Once a year, send them to the lab. You documented you're adherent with the UCLA guidelines. How many people know Schedule 3 and 4? How many refills can you have? I don't know why I did not learn this. You can prescribe once with 6 refills. That's it. So if your patient says, no, I'm going to come back in 9 months, your answer is, well, I can't give you 8 refills. I can only give you 6. So you have to come back if we're prescribing a Schedule 3 or 4. So just important, it's another safeguard on your license because we're asked to ensure pharmacovigilance. What does that word even mean? I mean, pharmacovigilance is we're being vigilant in prescribing controlled substances. And we're having these conversations with the people we treat. What are the requirements for cures? So I think a notice about the prescription monitoring is very important for all of you to understand. If your patient makes a complaint, the medical board can go to cures and get your cures report. So the report for you as a prescriber. Now that was looked at, is that legal? That was contested, but because prescription information is at the pharmacy, at the SURE, it's in the record, it's not considered secure. That's under the framework that the medical board can go get your cures, which can potentially open up multiple investigations, particularly if you're issuing overlapping prescriptions for controlled substances. Now, why doesn't Cures give us that feature? I mean, I would like that, because then I could say, oh, you know, in the last year, this person has asked for an early refill 5 times. I'm so busy, I didn't even realize that. And so that, but right now, that's not a feature. So we need to do that, engage in that pharmacovigilance, and then have those conversations. So cures is important. The requirement is that you run it within 24 hours or the previous business day before prescribing, and you query every 6 months. There's an interface, right? UCLA tried to help us so that we can, without leaving, log on directly to Cures. That's an convenience, and we're all appreciative. But if you check Cures and your patient had been getting it from multiple prescribers, there's not going to be pop-ups and alerts. So in those situations, you log out of Epic, or you also log into Cures, and there you may have a doctor messaging you saying, I asked you not to prescribe, I've assumed their care, and you're like, how was I supposed to know that? You sent it through to me through Cures, and I have an interface that streamlines the picture that I'm getting. So if there's a concern, go through the other portal, just log right in, the DOJ, Department of Justice website. So I think it's so important that we think about this privilege we have and how to safeguard it. And so I just want to urge what we've covered which is really staying on top of your medical decision making. Stay informed, come to these grand rounds, subscribe to the medical board newsletter, even if you just read the lead story. Sometimes it's because there have been regulations that have changed, and I mean, my hobby is the medical board, and I have not known. And it's like, how is this information being dispensed if I don't know it? So really good to find a way, because the last thing you want is an untoward bout and you didn't check Cures and you didn't do this and you didn't do that and you didn't even know it was a requirement. So very important. Supervision consultation, if it's a boundary or patient care, your consultations, your consultation groups, your psychotherapy groups. Risk management are your friends. You can call them, your professional insurer, and the physician's health committee, also called the well-being committee, is really here for you. And my last advice, if you had a DUI or something, and the DUI said, oh, don't worry about your medical license because I can tell you what to do. Immediately have your red flag and go up, because just as we specialize, attorneys specialize. Really important if you have a medical board action to know that there are medical board attorneys will say, oh, DUI, these are the potential consequences to your medical license. This is when you need to file. This is how long you have to file. These are the consequences if you don't file. And so they're going to guide you through protecting your license. So very important. And we all are working hard to avoid these other 4Ds and not be dated, duped, disabled, or dishonest. We want to be pharmacovigilant and vigilant in general about our practice of medicine. So I want to stop and make sure we can, and Larissa's going to help us look at the questions. So let's pull that up. And I think they're in the chat or Q&A, maybe both.
Q&A. Thank you, Dr. Miotto, for such an engaging and digestible, practical talk today with so many pearls that we can all use. So I will help to facilitate the Q&A. Please put your questions in there. One is, if there is a report against a doctor, will their license be suspended while the investigation is ongoing, or only if an investigation proves wrongdoing?
What we've seen is there's a difference between license suspended and a healthcare institution putting a doctor on summary suspended. So the medical board investigation process can be quite long. But for example, an institution can definitely put a doctor on summary suspended, so they are unable to practice medicine while that's being evaluated. I hope that answers your question.
Okay, great. So here's here. And also want to open it up to our audience if you have live questions as well. If not, I have one. If you could explain a little bit more about the cannabis bill and where that stands and intersects with the current status of, as you were alluding to, federal institutions like the VA, other institutions that do require pre-screening testing for cannabis, but this bill seems to contradict some of that, but allow for certain provisions. Meaning, is there anything on the horizon that physicians should be aware of related to this cannabis legalization in some states, but not at the federal level? Just a little bit more about that.
Yes, I think every institution I've talked to, their attorneys are actually weighing in on this, given if they fall under the drug clean workplace, if they're a federal institution. For example, the bill exempts if you're a transportation worker. So if you're driving, they can be tested on the spot. So I think there's going to be refinement around physicians. And so I wish I had a better answer, but I think it's wait and see as different legal minds weigh in on the interpretation, as well as the different labs. Some of the labs are saying we can't do that panel, we can do this panel. So my goodness.
Right, so it's an evolution.
Yes.
Evolving issue. Okay, great.
If I could just answer one question that I get frequently called about is, if a patient comes and they're completely impaired and they're a physician, can you treat them? And I'm always surprised at that question, but I appreciate that doctors are feeling very conscientious, like, oh, I don't want this doctor to enact harm. But it's very important that doctors have the ability to get treatment without every office they walk into to get treatment, they're going to be reported. It puts a burden on us as caregivers how to really address any concerns we have about the practice of medicine. And so often we're pulling out all our stops, bringing in family members, recommending a higher level of care to make sure if they don't have insight, that they get the proper treatment.
Yeah, that's actually a good point and topic. If one is treating a physician who discloses some impairment in addition to offering resources like the wellness committee referral or other treatment resources, would you say that consulting with risk management is also an option? That when in doubt, you have your own confidential resource to run something by.
That's really an excellent recommendation. Definitely consult with Rick, because there have been cases where people, a doctor wrote in the medical record, I called the Medical Board of California on this doctor. And that was actually a heck of a violation. So you need to know from risk management sort of what direction and to work hard to engage that professional in medical treatment, because of course you want to keep them safe, but also you're thinking about their patients. That's why referring to the physician health committee is also a good option. Normally, if you're in a state where there's a physician health program, you can just call it a state PHP, and the state PHP can call the doctor and say, I don't know if this was reported to the medical board or not, but this is pretty serious. You should come in for an evaluation and, potentially clear your name.
Great. One more question, Dr. Miotto. Can you comment on attendings, medical and legal liability of impaired residents or students, or any inappropriate conducts that we are not aware of until after the fact?
So if attending, I want to make sure I answer this question. If an attending is concerned, and so now we're talking about learners. And so if you have a learner, I think it's very important to bring in the program director and to report your concerns so that we can promptly find out the appropriate avenue for that learner to get treatment. I just want to give a shout out to the Florida program, the Florida State Physician Health Program. Without charge, because they got independent funding, will treat medical students and residents for substance use disorder. So, I mean, it's definitely a goal in the state of California.
Yeah, right. So the theme really is to get consultation, but because each decision might be nuanced, complex, and ultimately we want to get the person into further assessment or evaluation or treatment step by step without jumping to a disclosure that might be harmful or even inappropriate, at the same time keeping patient safety in mind.
And I really feel for the chief residents. Sometimes they'll have a junior resident who says, don't tell anyone, but I'm X, Y, and Z. I mean, what a burden. So those chief residents need to get consultation.
Exactly.
Because those can be life-changing decisions, and get support around them.
Yeah, talk to a supervisor or program director first. I think that's it for questions, unless any remaining here. And if not, thank you, Dr. Miotto. Thank you all for joining today for this engaging talk.
Yeah, appreciate the opportunity to be here with all of you.